welcome to Health Talk. I'm your host, Angela Baracco Eddy, and with me tonight is Dr. Patrick Reilly. He is a board-certified gastroenterologist with the Baptist Division of Gastroenterology Associates, and you can find him at the Endoscopy Center on Davis Highway, as well as Baptist Hospital and Baptist Medical Park. Tonight, we will be talking about pancreatic cancer and chronic pancreatitis. We are live this evening, so if you have any questions or comments, please give us a call. The numbers will be on the screen throughout the program. The local number is 432-7768, and outside of the Pensacola area, the toll-free number is 1-800-950-2522. The Endoscopy Center has a fantastic website also that has a lot of information on it. You can check out the website at www.endo-world.com. And on that website, you can find information about the different locations where you can find the physicians, as well as information on the doctors themselves, some frequently asked questions, links to other websites that might give you additional information. Lots of fantastic information on that website. So check that out if you have any questions. That's always a great place to start. Again, tonight's topic is pancreatic cancer and chronic pancreatitis. We would love to hear from you, so give us a call if you have anything that you'd like to ask or share. And with that being said, Dr. Reilly, as always, it's good to see you.
Good to see you. So I'm glad to be here.
I always like to get started with what is gastroenterology and kind of start with the basics, and then we'll get more specific throughout the program. So let's just get started with that first. What is gastroenterology?
Gastroenterology is a study in medicine of internal medicine, meaning organs that are inside the body, of the organs that are related to the digestive system. So the esophagus, the stomach, the small intestine, large intestine particularly, are the organs that are involved in digestion and absorption of nutrients to help our body grow and help sustain our body. Additional organs are the liver, and that's actually sometimes divided into a hepatology subspecialty, but it's usually typically covered with gastroenterology. And then also diseases of the bile duct or the biliary system and the pancreas, and that's kind of where my area is involving predominantly the pancreas. And the pancreas is one of the organs of the GI system that helps with, particularly with digestion.
What is the specific function of the pancreas, and why is it so important?
Well, it has two functions. It's actually almost like two different organs, and interestingly, it starts as two different organs, although not the two separate organs. They kind of are two organs mixed into one. The main function that they have is, well, there's two main functions. So one function is of the insulin production or glucose control, blood sugar control, and that's obviously a huge part, and that's where diabetes and some of the other more rare diseases, but particularly of diabetes involving blood sugar and either too high blood sugar or too low blood sugar affect the pancreas. The main function that we work with is actually the digestive portion of the pancreas, and they are interspersed. About 95% of the organ is related to digestion, or the glands that are related to digestion. And these release enzymes that break down proteins and break down sugars or carbohydrates and help them get into smaller pieces, so then the body, the small intestine, can then absorb them. They also release some things to help neutralize the stomach acid. The stomach produces a lot of acid, and that stomach acid is not necessarily good for the rest of the system, and so it actually helps release bicarbonate to help neutralize some of the stomach acid.
What are some of the things that could go wrong with the pancreas?
There's a lot of things that can go wrong with the pancreas, unfortunately. Like most parts of the body, they're very, very complex. They have a lot of moving parts, so to speak, or a lot of different enzymes, a lot of different chemical processes going on. The main thing that the pancreas does is obviously make enzymes that can help break down the foods, and so the number one thing that can go wrong is that it doesn't make those enzymes, or those enzymes don't get released or put into the proper place. Acute pancreatitis is actually when the pancreatic enzymes, for whatever reason, don't get outside the pancreas, and they end up staying inside the pancreas and causing inflammation or digestion, basically, of the pancreas itself. And so that's acute pancreatitis, and that's a very common illness, and we see that a lot of hospitalizations for acute pancreatitis, and that can be a lot of different reasons for acute pancreatitis. If the pancreatitis is recurrent or relapsing or is a chronic process, and we call it chronic pancreatitis, and that causes scar tissue and dysfunction of the pancreas, and so the pancreas no longer is working well. The other thing that can go wrong, one of the things that can go wrong with the pancreas, is that the cells, basically like any other cells of the body, if they end up misbehaving and end up doing, basically functioning on their own without kind of being aware of other cells around them, they basically become what we call malignant or invasive, and so those cells basically become disruptive and end up interfering with the function of other cells, the more normal cells around them. And so that's one of the problems or one of the main diseases with pancreas. A lot of diseases can present, and most of the diseases of the pancreas present in adulthood, but some of them, such as cystic fibrosis, which is actually where cystic fibrosis got its name, is actually a disease of the pancreas. Other diseases, we sometimes see hereditary pancreatitis, some of the diseases affect children, but predominantly a lot of the diseases that we see involving the pancreas are as you get older and either related to other medical conditions or related to medications or related to just exposure or other things that may happen to the pancreas as we live.
What might be some of the symptoms that someone might have if they have acute pancreatitis? Let's talk about that first.
Right.
What are some of the things that someone might present with?
Acute pancreatitis generally is severe pain, and it ends up usually developing as a severe pain usually typically located in the top part of the belly, and it goes to the back. It's typically an unrelenting type pain, kind of constant type pain. Occasionally it can be radiate or go up to other areas such as up to the right shoulder, but usually typically it goes to the back. The pancreatitis, the acute pancreatitis, also is usually associated with worsening when you eat food. It typically is once you eat a meal, particularly a fatty meal or a heavy meal, it tends to trigger it and cause it to get more inflamed, more irritated. Also usually typically associated, particularly in more severe cases, of nausea and vomiting. And if that nausea and vomiting is bad enough where people can't keep fluids down, they start to get dehydrated, they certainly need to get in the hospital, and that's an indication for being in the hospital to try to keep fluids and stay hydrated.
Those symptoms could be associated with other conditions or
Absolutely.
diseases. So how do you diagnose pancreatitis?
Right. Typically, usually, obviously, the pattern of the symptoms is typically when they occur, and what the pattern is a clue to it. But oftentimes we actually use lab work, and the lab work we use is actually some enzymes that are released by the pancreas that we can actually measure in the blood. If they end up going outside of the GI system and into the bloodstream, then we can actually measure those in the blood. So that's a simple blood test that's usually available fairly quickly in any lab. And that's an amylase or a lipase level, and typically those are, in acute pancreatitis, very elevated, and they tend to show a sign of acute inflammation or a lot of irritation in the acute setting.
If someone has those symptoms that continue going on, if it becomes a chronic condition, what might be some of the causes of that chronic pancreatitis?
Right. There's a lot of different reasons for chronic pancreatitis, and one of the most, anytime that you have acute pancreatitis, that you have something that is basically causing a relapsing or a recurrent nature of the acute pancreatitis can lead on to chronic pancreatitis. And there's can be some hereditary conditions that would cause you to have a recurrent bout of pancreatitis. Sometimes it's the way the plumbing of the pancreas works, and if you're born with a plumbing system that is not able to handle as much of the enzymes as it should, that can be an issue with it. Some of the most common reasons for having acute pancreatitis, and therefore then later on chronic pancreatitis, is alcohol, and alcohol is one of the more common reasons in the United States for develop acute pancreatitis, and that can vary quite a bit. You can have people who drink a large amount of alcohol and never end up having a problem with acute pancreatitis, and you can have people who drink a moderate amount of alcohol and end up having problems with acute pancreatitis. A lot of times that has to do with the genetics and how the body ends up, if there's other problems or other changes that allow the pancreas also to be inflamed or increase the risk of inflammation with it. Gallstones are one of the more common reasons for developing acute pancreatitis. Rarely that can go on to become a chronic condition or chronic pancreatitis, but typically if your gallstone is formed in the gallbladder, or actually even sometimes even in the bile duct by itself, and it gets stuck on the way out where the bile duct and the pancreas duct empty into the small intestine, it can be a point of where it backs up, and if it gets hung up there, if the gallstone gets hung up there trying to get out of the bile duct, it can cause a backup into the pancreas, which then causes those enzymes, those digestive enzymes, not to be able to get outside out into the small intestine where it needs to be, and it stays in the pancreas and causes a lot of inflammation, irritation.
If someone has been diagnosed with acute pancreatitis, what are some of the treatment options that are available for that? Because
as opposed to ugly pancreatitis. Acute pancreatitis
Exactly.
is right. The acute pancreatitis is a matter of basically we treat it very similar to the pancreatitis of 20 years ago or 30 or 40 years ago. And the main thing is hydration. The main thing is making sure that the volume that the person stays hydrated, because we know that the more dehydrated they become, the actually worse the pancreatitis can become. So one of the key elements is making sure they're hydrated enough, and that's usually typically requires IV fluid in a severe case, or using some type of electrolyte, Gatorade, Powerade, some Pediasure, and those kind of things that allow to stay hydrated. But a lot of times, oftentimes in the hospital, we use IV fluids, and that's basically the mainstay of treatment. And then we end up having to wait it out and basically try to keep the pancreas from getting any further inflamed. So oftentimes we may end up holding the diet for a short time period, although we used to hold it for a lot longer period. Now we actually try to introduce the diet a little bit sooner, because there are some benefits with having a minimal diet introduced early in the process. And so we may end up using a tube or something else to introduce a very elemental type, a very basic type diet to help with that. But oftentimes it's IV fluids, nausea medicines to try to keep the person from being dehydrated, from further vomiting, pain medicines oftentimes, because it typically is very, very uncomfortable, very painful, and then supporting them if there's developing some type of other problems because their blood pressure is dropping, or because they're having other problems, they may end up having to do other supportive measures for the acute pancreatitis.
It sounds as if from that discussion there's a lot of hospital time. How common is it that if you have acute pancreatitis that you end up hospitalized for that?
I think it's certainly one of the more common diagnoses that we end up having to bring into the hospital. And so with the acute pancreatitis, it's a life-threatening, kind of immediate life-threatening kind of condition. So oftentimes we want to watch it in the hospital. Occasionally it may be able to manage as an outpatient if it's a mild case of pancreatitis. And that's a big difference between acute pancreatitis and chronic pancreatitis, where chronic pancreatitis is typically an outpatient management, and is usually not the life-threatening acute emergency type situation as a acute pancreatitis would be.
Now, when you say that it's a life-threatening situation, obviously that's quite serious, obviously.
Right.
What causes it to be life-threatening? I know that you've talked about dehydration, you've talked about the vomiting, you've talked about the severe pain. None of those things in and of themselves may be life-threatening. So talk about what makes it so critical.
With acute pancreatitis, it's a matter of keeping the volume, or keeping the blood pressure up enough that you're perfusing the other organs, namely, usually typically the kidneys, or even actually there can be a inflammatory response. Basically, the body is having so much inflammation related to the inflammation in the pancreas that spills over into other organs, particularly the lungs. If you're giving a lot of IV fluids and then you have this effect with the inflammatory response, it can cause difficulty in the lungs, can cause difficulty in the rest of the body, and basically the fluid is not going where it should be going, and there's a general disruption in the whole body with the fluid status, and so the fluid ends up going where it shouldn't be, and instead of where it needs to be in supporting the blood pressure in the vessels, in the blood vessels. So.
Now, there's two functions, again, of the pancreas. So with this acute pancreatitis, we've talked a lot about the enzymes and how that's a problem. But with this inflammation, does it also cause a problem with the glucose control and the insulin control?
It can, but not as much as you would think.
Okay.
Because most of the pancreas, again, is about 95% of the pancreas is related to the digestive function, and a very small percent is related to the insulin production. And you can also, your body does a very good job. It has a lot of redundancy, or a lot of overlap with the insulin, because that's obviously a very, very key important function. So your body protects that quite a bit. And so in order to develop diabetes, you actually have to lose a large amount of the insulin producing cells or to develop a type 1 diabetes. There are type 2 diabetes, which is more of an insulin resistance, meaning your body's making enough insulin, it's just not doing what it should be doing. It's an insulin resistance. But if the blood sugar does get affected, that can be obviously a very serious condition. We do see it occasionally in acute pancreatitis, and that's a very serious sign that the pancreas is very, very inflamed or infected and may be causing it as well.
Again, our topic this evening is pancreatic cancer and chronic pancreatitis. We've been talking about some of the basics so far. We would love to get your call if you have a question or a comment. The numbers will be on the screen throughout the program. It's time for us to take a quick break, but right after that, we'll be back with more Health Talk.
Your word is gastroenterologist.
Can I have the definition?
A physician who specializes in diseases of the digestive tract.
Can you please use that in a sentence?
When stomach pain persists, you should see a gastroenterologist.
Could you tell me where I could find one?
The Endoscopy Center on North Davis Highway has a highly trained staff of 12 gastroenterologists who are ready to serve all of your gastrointestinal needs.
G-A-S.
Your first date. Your first job interview. Your wedding day. Your first baby. The firsts of everything can be scary, but you survive. Your first endoscopy may increase your chances to survive. Colon cancer screenings can save your life. If you won't do it for yourself, do it for the ones who love you.
The Endoscopy Center of Pensacola is an ambulatory care center designed with the patient in mind. Conveniently located on North Davis Highway, the center specializes in outpatient endoscopy. This is the direct visualization of the digestive tract with a video camera. Several different types of procedures are performed involving the esophagus, stomach, small intestines, rectum, and colon. All procedures are performed by board-certified gastroenterologists. Ask your doctor about the Endoscopy Center or call 474-8988.
Hello and welcome back to Health Talk. I'm your host, Angela Eddy, and with me tonight is Dr. Patrick Reilly. He is a board-certified gastroenterologist with the Endoscopy Center and Gastroenterology Associates with the Baptist Division. You can find him at the Endoscopy Center on Davis Highway, as well as Baptist Hospital and Baptist Medical Park. If you need information on how to contact those different places, check out the website for the Endoscopy Center. That will also be on the screen throughout the program, but it's www.endo-world.com, and that has all of the contact information. And of course, you can always call the Endoscopy Center. They can get you where you need to be. Tonight's topic is pancreatic cancer and chronic pancreatitis. We've been asking for calls, so if you have a question or a comment and you'd like to give us a call, please do so. Right before the break, we did have a call come in, so I want to make sure that we get to the caller and get to the phones. Hello there, and thank you for calling. Do you have a question or a comment for Dr. Reilly?
Yeah, if you have been diagnosed with chronic pancreatitis, and then they put you on a enzyme tablet, I think it's Creon. What I'm wanting to know is once they put you on them enzymes, do you have to stay on them until you die? What's the status for that? Do you know?
Yeah, the reason for being on the pancreatic enzymes, and that's a great question. We use in chronic pancreatitis to help. Basically, chronic pancreatitis comes to the point when either you've had acute flare-ups or multiple times that the pancreas has gotten inflamed, or it's been chronically inflamed for long enough that you develop a lot of scarring or replacement of the normal tissue with scar tissue, and so it no longer has quite the function that the digestive function that you would normally affect. And sometimes that will affect the blood sugar and cause what we call a brittle diabetic, or a person that has very difficult control with the blood sugars going up and down. But with the digestive function, the pancreatic enzymes, the thought is it does two things. One, hopefully it helps with pain, and it actually does multiple things, but it hopefully helps with pain by causing the pancreas not to have to work as hard. And the analogy I usually use is it's like a leg brace. Most people know with a leg brace or a cane that the leg still works, but it just doesn't work as well. And if you use it too much, it tends to get inflamed or irritated. And that's what we use with pancreatic enzymes, that basically the pancreas still works, but it just gets irritated or gets worn out a lot quicker. And so the digestive enzymes help relieve some of the workload that the pancreas has to do. And so we may vary the dose of that pancreatic enzyme. Typically, we try to get up to a pretty good dose to make sure that it's actually working or not working. Sometimes we can reduce that dose down, but what it does is we think that it helps with inflammation, with the chronic inflammation, that it basically less work on the pancreas causes less inflammation and causes less irritation. We think it also helps some with pain control or symptom control, because basically you have less inflammation, less nerves are getting fired off, and less signals to the brain that it's uncomfortable or painful. And then we also, oftentimes what we use late in the disease, you can develop a loose stool, what we call a steatorrhea, which is a loose stool, and that's often one of the first signs that people may have a pancreas problem, and they may not even know it. And sometimes it can be fairly unsuspected, saying, well, I couldn't have any problem with my pancreas. I've never had a bout of pancreatitis. And sometimes the first presenting sign is the loose stools, and oftentimes it may get diagnosed with IBS or irritable bowel syndrome or diarrhea, other conditions causing diarrhea. And so those enzymes help with the basically breaking down of the food products so they don't pass through, they don't cause a diarrhea, and it ends up helping with that. To answer your question is, yeah, more than likely, once you develop the scar tissue, sometimes you can get a little bit better, and the body does a good job of regenerating things. Certain organs, like the liver and some other organs, can regenerate a little bit. But scar tissue, generally, once it's scar tissue, it's hard to replace it with normal tissue again. And so if you have to be on pancreatic enzymes, it's generally one of these things that is a lifelong process. Sometimes, depending on diet and other things that can modify, if you take away some of the risk factors that cause, if you can find the risk factors and take away the risk factors that cause the pancreatitis in the first place, then you can take off the enzymes. But oftentimes it is important to stay on it just because it prevents further damage. Just like your blood pressure medicine, you don't take the blood pressure medicine because it's causing necessarily symptoms right now, but you're trying to prevent symptoms later on down the road. One of the biggest risk factors for pancreatic cancer is chronic pancreatitis, and that's a huge risk factor for pancreatic cancer. And so there is some thought that the pancreatic enzymes and the decreased inflammation may end up being a decreased risk factor in other ways, although that hasn't been necessarily looked at in the good enough quality studies to say that it makes a difference with those enzymes. But the thought process is that you're preventing further damage to the pancreas, and therefore it may end up helping in other ways that we don't necessarily see. So does that answer your question?
Yes, it did.
Okay. Any other questions regarding the pancreas, or?
I think that's it.
Okay. All right. Absolutely, sir.
All right.
Thank you for calling in.
Thank you very much for your call. Again, a great question, and it brought up pancreatic cancer, which is something that we are going to talk about in more detail. Does acute pancreatitis always lead to pancreatic cancer?
No, and acute pancreatitis generally is not a large risk factor for pancreatic cancer. Acute pancreatitis is a risk factor for chronic pancreatitis, which is then a further risk factor for one of the risk factors for pancreatic cancer. Generally, acute pancreatitis does not significantly increase the risk, or we don't think it significantly increases. A single episode of acute pancreatitis does not significantly increase the risk of pancreatic cancer. And obviously, pancreatic cancer is a very scary disease. It's a very disease that a lot of people hear about and know it is a very serious disease. But chronic pancreatitis, most people with acute pancreatitis will never get chronic pancreatitis. But if there's a reason that you had acute pancreatitis and you don't change that reason for having acute pancreatitis, such as if it is related to alcohol and there's continued heavy alcohol use or even continued alcohol use in general, then it ends up causing an increased risk of developing further episodes of acute pancreatitis, which has a effect on causing chronic pancreatitis or scar tissue of the pancreas.
We've talked about a few of the risk factors. We've mentioned just once or twice. Alcohol has been brought up several times. Are there other risk factors, smoking, diet, anything else that we can talk about?
Interestingly, with pancreatic cancer, is the risk factors with alcohol is less clear-cut. With chronic pancreatitis, alcohol certainly plays a role, and particularly in acute pancreatitis, alcohol plays a role. It's less clear in pancreatic cancer what the role that alcohol plays. Smoking is actually a huge unrecognized or under-recognized fact. When people think about smoking, they obviously know about the risk factors associated with heart disease and lung disease, and they also know the risk factors associated with other certain tumors and other problems, COPD, emphysema, those things. One of the things that people don't realize is how much it affects the colon, and what a large risk factor it is on the colon, how it affects the pancreas, and what a large risk factor is for pancreatic cancer, and also bladder cancer that is often not understood. And basically, it's pancreatic cancer. It's one of the more common reasons. Smoking is one of the more common reasons to develop chronic pancreatitis from a bout of acute pancreatitis. If you continue to smoke, it changes things, particularly some people with certain genetic reasons. So in some people it's a huge risk factor, in some people it's less of a risk factor with smoking. But it's one of the things that probably increases your risk of pancreatic cancer anywhere from 6 to 8 times with smoking. So it is a large risk factor. And the interesting thing is they've looked at if you stop smoking, does it make a difference? And that's a big thing, because people say, well, I've smoked all my life, I'm not going to stop now, because if I have it, I have it. And that's not true with a lot of diseases, particularly heart disease, and also even in pancreatic cancer, something as serious as pancreatic cancer. cancer. If you've quit for 2 years, it decreases the risk by 50% over if you didn't quit. So it actually makes a huge difference. I already dropped it in half after 2 years. After 10 to 15 years of quitting smoking, it almost goes down to the same risk as if you didn't, as someone who didn't smoke. And so after about 10 to 15 years, it's a long time to quit smoking, but if you had quit for 15 years, your risk factor basically becomes almost the same as if you didn't smoke.
So that's a huge argument to
Right.
stop smoking just to reduce your risk of pancreatic cancer. That's,
Correct.
That's pretty incredible. We've had another call come in, so I want to make sure that we get to the phone. Hello, and thank you for calling. Do you have a question or a comment for Dr. Reilly?
Yes, ma'am, I have. I have had a Whipple procedure, and I cannot take the Creon because it gives me real bad headaches. So is there anything else that I can take that can help me?
Yeah, Creon is one brand, and obviously it's come up twice now, so it's probably one of the more popular brands on it, and I use it quite extensively as well. I like the product, but there are several other pancreatic enzymes that are available out there, and so it is worthwhile trying one of the other pancreatic enzymes. There are several different brand names out there. There used to be more. The FDA a few years ago, probably about 5 or 6 years ago, made all the pancreatic enzyme companies, because they were actually grandfathered in. They had been around before basically the FDA was around, and so but the pancreatic enzymes not long ago ended up having to go back and prove, even though it was one of those things that people knew made a difference in certain diseases, particularly cystic fibrosis and such. They had to go back and prove that they were effective medications. Some of the companies looked at it and saw that these medicines were older and didn't decide to go through that FDA process, and so we have less of them now than we did 10 years ago, but there are still about 6 to 7 different brands I can think of off the top of my head that would be potentially ones to try for it. So even if you don't necessarily can't tolerate one because of the side effects or the headaches, it may be that you can actually tolerate another one, because headaches are not uncommon with any medication, and so it's one of those things that with any one particular medicine, it may be much more effective and without side effects. It's not usually a class, meaning that all the drugs in that all the drugs that are related to that medicine cause that side effect. Usually, typically, it's a side effect with just that one medication.
Oh, with just the one? Okay.
Yes, ma'am.
I'll check further into it.
And why did you have the Whipple procedure?
Because my doctor told me I had to have it.
Okay. What disease did you have that they told you that you had to have the Whipple procedure? Did you have pancreatic cancer?
They said it was cancer.
Yeah. And how many years ago was that?
It was just 2 years ago.
Okay.
About 14.
Okay. How many years ago? 2014?
14. It was in June the 25th or the 26th. Dr. Reeves at that hospital.
Okay. Well, good. Excellent. We're blessed that we have a lot of skilled surgeons in the area. For this size area, we have both some of the technology that a lot of areas this size don't have, and then we also have some of the surgeons that basically a lot of areas don't have that the skilled set of the surgeons that we have that can work on pancreases.
Okay.
And so, yeah, I'm glad you're doing well from the tumor standpoint, and with the enzymes, I think it's important to talk to your gastroenterologist and say, can we try something different? Are there any other products out there? Oftentimes we have some samples in the office, and we can sometimes get some assistance with the other samples to try to help start out and see if you tolerate those and make sure you don't have the side effects of the headache.
Okay, then let me, my doctor, I was just at his office here a couple of days ago, and we were discussing this situation, and he said that he thinks that they've got a powder out now that you can sprinkle on your food, but he said he wasn't going to get involved in that just yet.
Okay. Yeah, the actually interesting, the digestive enzymes, most of them, as long as they're capsulated, meaning they don't break down, you can actually open them up and actually sprinkle them on the food, which tends to make it easier to swallow. You just have to make sure that with either talking with the pharmacist or your physician, that make sure it's a type of medication that won't get broken down in the stomach. And usually, typically, that's a capsulated or a covered They're little spheres inside the medicine. It's usually made up of little tiny spheres, and they don't get broken down. And Creon's kind of nice because they're smaller, so they get into the small intestine a little bit easier. That's one of the things that they promote with that. But there's several of the other products are also out there and available, and it may be worthwhile trying one of the other enzymes, and particularly if you can open them up and sprinkle it on your food, it would make it a lot easier to take it. Typically what we like to take the Creon is when you first take your first bite of food is when you take basically the enzyme. So we want it to mimic your body as much as possible. It's not going to be the same as your body. It's a medication. It doesn't work as well as God designed the original system. But it is a product that is if you take it when you first take the meal, helps break down the food and helps break down the sugars and helps break down the proteins.
Okay.
Yeah, so I'd strongly recommend that you try the different type of enzyme. So I think the quality of life would probably be better with taking the enzymes than without taking the enzymes.
Okay. Well, what is the use of protein? Does it? How does it work? Does it work as an enzyme?
Protein is actually is one of the types of parts of the food, and basically you have to break down the big strands of protein into amino acids in order to absorb them in your body. So what the enzymes do, what the pancreatic enzymes do, is they break down and cleave and chop up that protein into very small pieces that make it then easy for your small intestine to absorb those small itty bitty pieces, where it makes it much harder. The big pieces can't cross through the small intestine and don't get absorbed. And so that's one of the things that you're losing, and you probably notice your muscle mass and some of the other things that you've lost as far as muscle function and muscle mass. And that's if you're not getting enough of the protein, if you're not able to absorb it because you're not able to break it down into the small itty bitty pieces, then your body actually interestingly takes those itty bitty pieces and reassembles the same proteins out of it sometimes, but inside the body. And so, but it takes those little small pieces and the building blocks of then it rebuilds those proteins into something you can use.
Okay.
So yeah, protein is just something that's one of the carbohydrates, proteins, and fats are the three parts of the food generally that we need in varying amounts to basically help build the body and help keep it strong.
Okay, I appreciate it.
Well, thank you very much. I appreciate you calling in, and I'm glad we could be of some help. So.
Okay, thank you very much.
Thank you.
Thank you for your call. We appreciate it. And again, it's time for us to take a quick break. We are going to come back after this with more health talk.
Your first date. Your first job interview. Your wedding day. Your first baby. The firsts of everything can be scary, but you survive. Your first endoscopy may increase your chances to survive. Colon cancer screenings can save your life. If you won't do it for yourself, do it for the ones who love you.
The Endoscopy Center of Pensacola is an ambulatory care center designed with the patient in mind. Conveniently located on North Davis Highway, the center specializes in outpatient endoscopy. This is the direct visualization of the digestive tract with a video camera. Several different types of procedures are performed involving the esophagus, stomach, small intestines, rectum, and colon. All procedures are performed by board-certified gastroenterologists. Ask your doctor about the Endoscopy Center or call 474-8988.
Your word is polyp.
Can I have the definition?
A growth or tumor protruding from the mucous lining of an organ.
Okay. Can you use it in a sentence?
If you have a polyp, you should have it removed by a gastroenterologist.
Could you tell me where I could find one?
The Endoscopy Center on North Davis Highway has a highly trained staff of 12 gastroenterologists who are ready to serve all of your gastrointestinal needs.
POL.
Hello and welcome back to Health Talk. I'm your host, Angela Eddy, and with me tonight is Dr. Patrick Reilly. He is a board-certified gastroenterologist with the Baptist Division of Gastroenterology Associates. And tonight's topic is pancreatic cancer and chronic pancreatitis. We've had some great calls come in so far. If you have a question or a comment that you would like to ask Dr. Reilly, give us a call. The numbers will be on the screen throughout the program. The local number is 432-7768. If you're outside of the Pensacola area, the toll-free number is 1-800-950-2522. Before the break, we had a caller that was asking some specific questions about a specific medication that she was on, and it brings up the point again how important the communication is between the patient and the physician. Dr. Reilly, I know that's one of those things that sometimes is a little bit frustrating because you just don't always know, but in a case like that, there are other options that can be tried. Right. And the important thing is to continue having that conversation with your physician.
And to bring up, if you're not taking a medication, the physician wants to know you're not taking the medication. They may want you to take the medication, but there's usually a reason that you're not taking the medication. It can be cost issues, can be headaches, like that particular patient that had side effects with the medications that were intolerable and unpleasant. And sometimes it can be then a discussion on, well, if you don't take the medication, you have these potential risks with it, and it may be something that says, well, the headaches aren't that bad, I can tolerate that. Or it may be something that the physician then says, you know what, we have something just as equal, and it's just as easy to write for something different as opposed to writing that particular product or writing that particular, doing that particular treatment plan, that maybe surgery is a better option for you versus not surgery doing it in the option. So it's real important to communicate, particularly with the pancreas and some of the things that have these chronic diseases that you're going to have for a long period of time, to communicate and say, okay, why am I taking this? Do I still need to take it? It's expensive. Is there any other assistance or any other help with it? Is there other products out there that may be just equally as effective? And I think that's important to have that discussion. Sometimes we substitute something, it may not be quite as good, but if you're not taking something at all, then that's probably worse than taking something that may not be quite as good, or a product that may be different than what the physician wanted, but it may be something that says, well, you can meet in the middle or find a mutual agreeable kind of solution to the problem, or at least try to fix that problem.
So again, if you're having any concerns or questions, make sure you talk to your physician about it, because sometimes it's something that they can help with, or they can do something a little bit different and kind of tweak the treatment a little bit to help you feel better and to have the quality of life that you're living even better. Yeah. So I want to talk again about pancreatic cancer. What are some of the risk factors? And we've talked about a few, but let's talk about some of the other risk factors for pancreatic cancer.
Pancreatic cancer is a very serious disease, and I think most people recognize when they hear that, they kind of get a little spooked or get a little anxious with it, and that's rightfully so. It's a very serious condition when diagnosed with it. And unfortunately, it's a very common condition. And actually, next month, November, is Pancreatic Cancer Awareness Month. And that's actually something that I feel strongly about. There's a group out there called PanCan, P-A-N-C-A-N, that ends up actually helping out and being a patient advocate and basically being patient awareness and actually helping with some of the support. And it's you can find it on the website. It's P-A-N-C-A-N, and just search for it. But November is Pancreatic Cancer Awareness Month. That's why we're wearing purple, or that's why I'm wearing purple tonight, is just to being awareness that they've adopted that color as to try to bring some awareness to the group. It is something that's very common, but is underrepresented in funding from some of the government cancer research, and part of that is because the disease is a fairly serious disease, unlike other diseases where you may have a lot of survivors for a long period of time. Pancreatic cancer, unfortunately, we don't have as many survivors. We don't have as many success stories as a lot of other things are, but we do have a lot more success stories than we did 10 years ago. And so it is making a difference, and there is a big difference with it. Pancreatic cancer, the risk factors, you can say, what can I do to minimize my risk? Some of the things you can modify, some of the things, unfortunately, we're dealt the hand that we have. Smoking, we mentioned that earlier, is probably the number one modifiable risk factor that we can have. We know it makes the biggest difference in the risk of pancreatic cancer. Obesity, particularly a BMI or a body mass index greater than 30, is shown to be a higher risk factor than people with a body mass under 23. Getting under 23 in today's society is pretty hard to do, but it is something that is, if you're able to get a body mass index lower, then we do know that makes a difference. Diabetes is potentially a risk factor. And the question, diabetes is very interesting because we don't know if it's a cause or an effect. Whether you have the diabetes increases the risk of pancreatic cancer, or does diabetes itself because you developed diabetes because of the chronic inflammation or because something else was going on in the pancreas that actually caused your blood sugars to be less, kind of more susceptible to develop diabetes because there was already something going on with the pancreas that was causing a problem with it. So that's thought to be a risk factor. And certainly keeping the blood sugars under control. And if you are diagnosed with diabetes later in life, particularly after the age of 45, is where a lot of people with type 2 diabetes are diagnosed, is just to say, okay, is there something else going on there? Is there something wrong with the pancreas? Is there something that should be checked out? We don't, at this point, routinely recommend screening for everyone with a new diagnosis of diabetes after the age of 45, but it is one of those things that we look at. Age, after the age of 45, is one of the risk factors. It's unusual to see pancreatic cancers under that age, but it does happen sometimes with hereditary disease and things along those lines. Hereditary pancreatitis, which usually typically develops with a pancreatitis under the age of 20. It can even happen in younger children under the age of 5, but hereditary pancreatitis, where you're having pancreatitis, these constant episodes, or have someone with a family history of pancreatic cancer. Family history of pancreatic cancer does make up about 10 to 15% of pancreatic cancers, so it is a pretty sizable chunk, and there are certain guidelines for screening if you have a family history of pancreatitis as well. As far as any other risk factors, one of the things I didn't mention was BRCA or BRCA, and most people are familiar with that in breast cancer. If you have the BRCA gene or know that you have that BRCA gene because a family member was tested for it and then subsequently you were tested for it, and there is a family history of pancreatic cancer, those people should probably be monitored very closely and undergo some type of routine screening or surveillance type program as well.
Let's talk a minute about the screening that might be available for pancreatic cancer, because I know one of the reasons that it's such a serious condition is a lot of times it's not caught until very late in the process.
And that's typically twofold. One is because the pancreas is a very well-hidden organ. It's deep down in the abdomen. It's well protected. And the reason why it's well protected is if you get hit by something or anything like that, unlike a lung or a liver or a spleen or something else, that may be able to heal itself pretty well. If you get hit in the pancreas and it were to disrupt the pancreas, then that becomes basically a huge inflammatory response, and you develop that acute pancreatitis. And so it's designed to be hidden and tucked away in the back of the body. It's also a difficult organ to look at with a scan or anything else along those lines, because it's almost like a lymph node or like a gland, in the fact that it's not a encapsulated organ. It doesn't have a nice round capsule around it. It doesn't have a nice smooth border that you can see, oh yeah, here it clearly ends and here it clearly begins. The pancreas looking at the pancreas becomes challenged. The other thing is also, oftentimes pancreatic cancer can go for a number of years without ever having any type of symptoms. And that's the tricky part of it, is that it may be something that's small or something treatable, but is presenting with no symptoms. Your body does a good job with the pancreatic. It has a lot of overlap, so you don't typically develop diabetes, you don't typically develop pancreatic insufficiency until later in the disease process, and typically you don't develop pain or other problems until late in the disease process. And so when pain starts developing, it often means that the nerves have been involved, and sometimes that can be early in the disease if it happens to hit a nerve that's nearby, but oftentimes that's actually after the tumor has gotten big enough that it does hit a nerve, and that ends up becoming very painful, very uncomfortable. So it's oftentimes late in the diagnosis. If we're not looking for it and don't have a high suspicion for it, it also tends to be gradually increasing, in the diarrhea or the pain, the belly pain, the top of the belly pain may be going on for some time without ever getting picked up or getting clearly diagnosed.
So what type of screening, if someone does have some of these risk factors, what can you do?
Yeah, right now the guidelines for screening are there's only a few disease processes that we actually recommend screening routinely. We usually typically start thinking about looking for it if there's a high suspicion, if there's some of those things that we talked about, a family history, if there's symptoms of diarrhea, if there's symptoms of pain in the top part of your belly, if there is new onset diabetes. Some of those things along those lines would cause us to look at it. Typically the screening tests that we look at, or the test to help us diagnose it, even if you've started presenting with symptoms, is typically a CT scan or an ultrasound, something done by radiology, and that's non-invasive, meaning we don't go inside the body for any reason except for an IV for the contrast. So CT scan or ultrasound, if they can get an ultrasound, it's okay. A CT scan's even better with looking at the pancreas, because because it actually gets a much better look at it than by a routine ultrasound. MRI of the pancreas oftentimes is used, particularly if you're trying to differentiate chronic pancreatitis versus pancreatic cancer. And then a test that I do, I was the first one in the area to come down into the region, and this has been now 12 plus years ago, doing endoscopic ultrasound, and basically that's using an ultrasound from the inside out. And that's oftentimes after a CT scan or MRI has been done, something that was non-invasive, because this is an invasive test. You end up having to go down inside, very similar to an endoscopy where you go into the stomach. So we go into the stomach and we use an ultrasound to basically look at the pancreas. People sometimes hear it of a transesophageal echocardiogram, where they've actually looked down and used the ultrasound to look at the back of the heart. We can see that with an EUS, but it's not really designed for that. It's more designed for looking at the pancreas, looking at the bile duct, looking at the structures that are immediately around the pancreas and the stomach. And that's oftentimes something that we can allow us to see the pancreas in a lot of detail. And with seeing the pancreas in a lot of detail, we may even be able to do a biopsy or a selective biopsy of the pancreas in order to look at and see how things are going.
It's time for us to take another quick break, but when we come back, again, if you have any questions or comments, please give us a call. But I want to talk about two things specifically: how common is pancreatic cancer, and what are some of the treatment options available. So when we come back with more Health Talk, we'll get to those things, and we'll take your calls when we come back with more Health Talk.
The Endoscopy Center of Pensacola is an ambulatory care center designed with the patient in mind. Conveniently located on North Davis Highway, the center specializes in outpatient endoscopy. This is the direct visualization of the digestive tract with a video camera. Several different types of procedures are performed involving the esophagus, stomach, small intestines, rectum, and colon. All procedures are performed by board-certified gastroenterologists. Ask your doctor about the Endoscopy Center or call 474-8988.
Your word is endoscopy.
Can I have the definition, please?
Endoscopy, a visual examination of the interior organs by use of an endoscope.
Can you use that in a sentence?
An endoscopy is a life-saving procedure that can detect the early signs of colon cancer.
Well, can you tell me where to get one done?
The Endoscopy Center on North Davis Highway has a highly trained staff of 12 gastroenterologists who are ready to serve all of your gastrointestinal needs.
E-N...
Your first date. Your first job interview. Your wedding day. Your first baby. The firsts of everything can be scary, but you survive. Your first endoscopy may increase your chances to survive. Colon cancer screenings can save your life. If you won't do it for yourself, do it for the ones who love you.
Hello and welcome back to Health Talk. I'm your host, Angela Eddy, and with me is Dr. Patrick Reilly. He is a board-certified gastroenterologist with the Baptist Division of Gastroenterology Associates. And tonight we are talking about pancreatic cancer and chronic pancreatitis. If you have a call, we'd love to get your question or comment on the air. The numbers will be on the screen throughout the program. Feel free to call us and we'll try and get you on the air as soon as we can. Before the break, we were talking a little bit about some of the risk factors and things like that for pancreatic cancer. And I want to just touch briefly again on what symptoms might someone exhibit if they do have pancreatic cancer. I know one of the things is it can go for years without exhibiting any symptoms, but if there are symptoms, what might those be?
Typically those symptoms are, one of the more common presenting symptoms is actually jaundice or turning yellow. And a lot of people will think that's actually related to liver disease or some problem in the liver, but it can also be related to something in the pancreas. And like we talked about before, with that gallstone getting hung up on the way out of the bile duct, if there's a tumor that's in the bottom portion of the pancreas, or what we call the head of the pancreas, and it's causing a narrowing of that bile duct, then basically causes it to back up, that bile to back up and not flow out. And you may notice a light-colored stool or a pale-colored stools, and also start noticing a darkening of the urine, or actually even a yellowing of the eyes or yellowing of the skin. And that's actually not an uncommon presentation with pancreatic cancer. Pain is also another one we talked about. Typically it's pain in the top part of the belly going straight to the back. Sometimes it's worse actually when you lay down as opposed to sit up. And that can present sometimes with that. That's actually sometimes nausea, other symptoms along those lines, but a lot of times just pain in general in the top part of your belly should be investigated. And if you're having those type of symptoms, it probably should be something that you talk to your physician about. And it could be something acid related, could be related to the stomach. But one of the things that should be in the back of the physician's head is that says, could it be the pancreas? Is there a problem potentially with the pancreas? And how do we evaluate that, or how should we look at that?
How common is chronic pancreatitis or pancreatic cancer?
Chronic pancreatitis is very common. I don't have the numbers on the chronic pancreatitis, but it is extremely common with it. Most people with chronic pancreatitis, like we mentioned about, can be handled or treated as a outpatient. They don't require inpatient admission. Occasionally it does require it for if there's a flare-up or other problems along those lines. Obviously, oftentimes amylase and lipase, those numbers that are sky high in acute pancreatitis may be relatively normal or even normal, or low or just mildly elevated in chronic pancreatitis. But digestive enzymes, avoiding things that can potentially cause problems. Pancreatic cancer is just under 50,000 people per year are diagnosed with it. It's the fourth deadliest cancer in men and women, so it is very common. It's something that has increased, and particularly in the Western society, we see it more often. Also in certain populations, such as Hawaiian population, Polynesian populations, African Americans, it's more common than in Caucasians. It's slightly more common in men than women, probably because some of the more risk factors with smoking and alcohol are more common in men and women. More common in men than women historically, although that's limiting. And so is the African American versus Caucasian ratio. It seems to be kind of becoming more of a 1-to-1 ratio as opposed to higher. So.
Higher. We've had another call come in, so I want to make sure that we can get to the caller. Hello there, and thank you for calling. Do you have a question or a comment for Dr. Reilly?
I do. I don't necessarily want it on the air.
If you'd like to hold until after the program is over, we can answer your question off the air if you'd be more comfortable with that.
I would.
Okay, well then if you don't mind holding for a few minutes, we'll get back with you in just a few minutes as soon as the program's over.
Thank you so much, Dawn.
Absolutely.
Yes,
thank you. Whoops. I might need... All right, hold on just a minute and we'll get you... Actually, I'm going to hang up with you. If you'll call right back in, they'll keep you on hold until after the program and we'll get right back to you, okay?
You want me to hold on or call back?
Call back, because I can't put you on hold from this phone. So if you'll hang up and call back, we'll keep you on hold.
Sorry about that. Thank you.
Thank you. Bye-bye. One of the things that I wanted to talk about real quickly is some treatment options that might be available for pancreatic cancer specifically.
Correct. One of the things, if we catch pancreatic cancer early, we can do surgery, and surgery is the curative process with pancreatic cancer. So undergoing surgery is the ideal situation if we can catch it early enough and undergo surgery with it. We are fortunate to have, like I mentioned earlier, several skilled, on air they mentioned one of the physicians that are very skilled with pancreas diseases, and certainly having a surgeon that feels comfortable with pancreatic diseases is very important. And we are fortunate in the area to have several physicians that are, several surgeons that are comfortable with pancreas diseases. Sometimes pancreas surgery is not an option. Sometimes it may or may not be an option, and we're not sure about that. There are certain things as far as with some of the treatment protocols and research protocols that may be available outside the area that we can potentially get you enrolled in, or potentially shrinking down the lesion with either radiation or chemotherapy, and that may shrink it down. It may not be necessarily curative at that point, but hopefully prolong things, or at least allow things to go a little bit longer. Unfortunately, we're not where we want to be. We have made some progress in the last 5 years. I mentioned that earlier, but we're not where we want to be with pancreatic cancer. And it's real important that from a funding standpoint and a research standpoint, that we continue to look at, what makes this disease so difficult. Besides being caught late in the disease process, what other factors are making it more difficult to treat and use therapies? Sometimes we can do pain control, and that can be a godsend for someone who is suffering with a lot of pain, and we can actually put a little small needle into where the nerves that feed off the pancreas and actually numb those needles. Sometimes we can do that in chronic pancreatitis, and we're sometimes effective in chronic pancreatitis, but particularly in pancreatic cancer, we're usually oftentimes very effective in trying to reduce the amount of pain, and typically by 50 to 80% we're able to get the pain knocked down, which improves the quality of life for someone who may be suffering with this disease process.
So again, if you have any concerns, if you have any issues, the most important thing is talk with your physician. If you've been talking with your primary care physician and they need to send you to a gastroenterologist, make sure that you follow up with them and make sure that you do what they ask you to do. What are some of the things that someone might need to know in advance of coming to see you? Do they need to have some medical history, some family history? What kind of questions are you going to ask?
Yeah, typically we usually ask about any family history, particularly of breast cancer, colon cancer, pancreas cancer, any other type of cancer that may run in the family. We want to know about smoking and alcohol history. And it's real important to be honest about that and about the amount of smoking or alcohol with it. It's important to know if they're on any medications that may potentially increasing the risk of pancreatitis. There are a few medications out there for diabetes as well as some other disease processes that blood pressure medicine, some of the things along those lines that increase the risk of pancreatitis. So it's important to know those factors. It's important to let them know what your symptoms are and be aware of that. So being aware of your family history and then also knowing exactly kind of when the symptoms started, or at least kind of beginning to tell whether the symptoms started a long time ago or more recently, is real helpful with pancreas.
And sometimes even keeping a journal of the symptoms and what you're having, what you're experiencing, and when can be helpful.
Absolutely.
To the physician.
Yeah, absolutely so.
Again, make sure that you follow up, make sure that you talk with your physician. November, again, is Pancreatic Cancer Awareness Month. So if you have any questions or if you'd like to learn more about that, the website you can check out is PanCan, correct? PanCan.
Yeah, PanCan. I think it's pancan.org, but it may be Google it.
But you can check it out, absolutely. If you search it, PanCan, that'll certainly get you to the right place. And that'll have some good information. It has some more frequently asked questions. It can link you to some other websites that can certainly get you the information that you're looking for. And of course, you can always call the Endoscopy Center. They are very helpful there. They can make sure to steer you in the right direction as well. And of course, I would be remiss if we did not talk for just a couple of seconds about screening colonoscopies. It is always important to check your insides out. If you're over the age of 50 and you have not yet had your screening colonoscopy, make sure you call your physician and you get that scheduled. It very well could save your life.
Absolutely.
Thank you so much for joining us. Again, this is Angela Eddy and Dr. Pat Reilly. We are very glad you joined us for Health Talk. We hope to see you more next time.